Good afternoon all, I am Dr. Brindha. I will be presenting on a case series of isolated white-eye viral endothelitis in healthy young, silent yet sight-threatening. Viral endothelitis is characterized by a triad of corneal edema with keratic precipitates and mild iritis as shown in the image. It can have 4 forms where disciform is the most common and herpes simplex virus is the most common etiology, and viral endothelitis is a known cause of corneal endothelial dysfunction in immunocompromised middle-aged and older adults. But in our case series, I will be discussing about the isolated white-eye viral endothelitis where there is an isolated corneal edema without anterior chamber inflammation. That is, the patient doesn't have any keratic precipitates, iritis, circumciliary congestion, high intraocular pressure, or there are no risk factors like systemic illness, immunosuppression, stress or ocular trauma. The objective is to describe the clinical presentation, management and outcomes of the isolated white-eye viral endothelitis in young, otherwise healthy individuals. I will be discussing about 5 atypical cases. All patients were treated on tablet acyclovir 400 mg 5 times a day for 2 weeks followed by BD for 4 weeks, and topically they were on lotiprednol eye drops QID with weekly taper, sodium chloride eye drops, topical antibiotics and lubricants. Resolution of corneal edema both clinically and on ASOCT was considered as a positive clinical response. Coming to the first case, it's a 21-year-old healthy female who had blurry vision in the left eye for a week with central and paracentral corneal edema without any congestion. Vision was 612 with a reduced corneal sensation and normal IOP. On slit, there was corneal edema with thickened DM endothelial complex. The epithelium was intact and no KPs and AZ reaction. This was evident on ASOCT with the increased CCT of 858 microns. On 1 month follow-up, the corneal edema resolved with the minimal haze and the vision was 6/6. The ASOCT shows the resolution. The second case is a 25-year-old healthy female who had blurry vision in the right eye for 2 days. Clinically, she had mild central corneal edema with faint decimate folds and without any congestion. The vision was 6/9 with reduced corneal sensation and normal IOP. On slit, there were faint DM folds and there were no KPs and the epithelium was intact. On the ASOCT, there were posterior stromal edema with endothelial irregularity and increased CCT of 686 microns. On 1 month follow-up, the corneal edema resolved completely on clinically and on ASOCT with a vision of 6/6. Third case is a 17-year-old healthy female who had diminution in the left eye for 15 days with the central dish-shaped corneal edema without any congestion. Vision was 612 with reduced sensation and normal IOP. On slit, there were thickened DM endothelial complex without any KPs and high CCT on ASOCT with 784 microns. On 1 month follow-up, the corneal edema settled with residual stromal haze, which was seen on the ASOCT also with the vision of 6/9. Fourth case is a 29-year-old healthy female who had diminution in the vision in the left eye for a month with a mild central corneal edema. As the patient presented late, she had minimal scarring also. There were no congestion. Vision was 6/12 with a reduced corneal sensation and normal IOP. On slit, there were posterior stromal scarring, and on ASOCT, the scarring was noted. Still, we started on treatment and the patient had drastic response with the resolution of the scarring and the vision resolved to 6/9. Fifth case is a 14-year-old healthy female who had diminution of vision in the left eye for 5 days with a central dish-shaped edema without any congestion. Vision was 6/24 with the reduced corneal sensation and normal IOP. On slit, there were corneal stromal edema with endothelial irregularity as shown in the ASOCT also. On 2 weeks follow-up, partially the edema resolved with the minimal posterior stromal scarring and the vision was 6/9. Coming to the discussion, all patients in our case series were very young, between 14 to 29 years, and all were females, and they were healthy and immunocompetent. In the review of literature, there was a single case report of corneal endothelitis in a juvenile male. In our case series, all were females. And in our case, early presentation had complete resolution. When the patient present late more than a week, they had minimal residual haze, but the scarring was also reduced on treatment. So early diagnosis is prudent to prevent the endothelial cell loss. The postulated mechanism of this white-eye viral endothelitis, whether it is a separate entity or it is a early phase of classic herpetic endothelitis, or is there any role of UV exposure, blue light or lifestyle modifications, or is there any hormonal imbalance as all patients were females, or is there any role of latency-assisted transcript causing early reactivation in healthy young patients? Take clinic points should be when a young healthy patient presents with isolated corneal edema with reduced corneal sensation, even when the IOP is normal and no KPs and no iritis, without any congestion, think of viral endothelitis and start the combination therapy of oral acyclovir with topical steroids, which is effective both in early and late presentation. Thank you.
Sure.
Do you think oral acyclovir in these cases is really effective? And for how long?
Sir, tablet acyclovir 400 mg BD for 2 weeks, 5 times for 2 weeks and BD for 4 weeks, 6 weeks of treatment as routine endothelitis treatment, sir. Hello, sir.
Why females?
So that's what we are postulating. But no one had any relation to menstrual cycle or not. We
Yeah.
asked history for that, but each one were in different phases of the menstrual cycle. There were no correlation, but we have to further investigate about this case. Without any congestion and keratic precipitates, young healthy girls are getting the corneal edema with reduced sensation. Girls in 14 to 28 years. Is a hormonal change or whether the
Kya, sir? And now they are mentally more intelligent, but physically still they are at the same place. Mentally they are stronger than us now, but physically they have some immunic problem. Okay, thank you, doctor.
Thank you, sir.
Thank you.
But I think dose of acyclovir is a bit less according to Parcel. Okay, no issue. But I said you just dose is less.